It is. It's about building a system where the right choice is the easiest choice. Why do doctors prescribe broad-spectrum antibiotics when they aren't needed? Often it's because the local guidelines aren't accessible, or the order set on the computer is confusing. NG15 puts the responsibility on the organization to fix that infrastructure.
And this isn't just happening in a vacuum, is it? We have this UK 5-year action plan for antimicrobial resistance, running from 2024 to 2029. I looked at the map and the source material. This is a 4-nation strategy.
It has to be. Bacteria do not respect borders. You can't have a great stewardship program in England and a terrible one in Wales because the resistant organisms will just, move. The source details explicitly state this is a collaboration between the DHSC, the Scottish government, the Welsh government, and the Northern Ireland administration. It's a One Health approach.
What do you mean by One Health?
One Health means recognizing that human health, animal health, and the environment are all inextricably linked. Resistance breeds in agriculture, in sewage, in hospitals. The 5-year plan is trying to coordinate all of that.
We're currently in 2026, so we are slap bang in the middle of this plan. The source mentions a 20-year vision. What does that vision look like? Or maybe, what are they trying to avoid?
They're trying to avoid the post-antibiotic era. Imagine a world where a hip replacement is too dangerous to perform because the infection risk is, say, 50%.
God.
Imagine where chemotherapy is impossible because we can't protect the patient's compromised immune system. The 20-year vision is to contain AMR so that modern medicine remains viable.
That really puts the pharmacist's daily grind into perspective. Every time you intervene on a prescription, you aren't just, annoying a doctor.
No.
You're holding the line for that 20-year vision.
You are the boots on the ground. The 5-year plan is a PDF on a government website. The pharmacist is the one actually executing it, one prescription at a time.
Okay, let's get to the friction point. The moment where these two worlds collide, we have sepsis speed from NG253 demanding immediate action and stewardship safety from NG15 demanding caution. In practice, this manifests as the concept of starting broad.
This is the daily dilemma.
So what does start broad actually mean in the trenches?
It refers to empiric broad-spectrum therapy. When a patient hits the ER with suspected sepsis, we don't know what bug they have. It could be E. coli, Pseudomonas, Klebsiella, strep. We have no idea.
So we use a carpet bomber.
Exactly. We use a drug or a combination of drugs that kills everything. We cast the widest net possible because if we miss the bug, the patient dies. NG253 essentially gives you permission to use that sledgehammer in the first hour.
But the stewardship side of your brain must be screaming. Broad-spectrum antibiotics are like ecological disasters for the body, right?
They are. They wipe out the gut microbiome. They select for the most resistant, nastiest pathogens to survive and take over. It's like nuking a city to catch one criminal.
You get the criminal.
You get the criminal, but the collateral damage is immense.
So how do we resolve this? You can't not treat the sepsis.
The resolution is in the de-escalation mindset. This is where the pharmacist really earns their paycheck.
Walk me through that. What does that look like?
Okay, so hour 0, you facilitate the broad-spectrum drugs. You prioritize survival. That's your only job.
Yeah.
Hour 48 to 72. The culture results come back from the lab. Now we know the enemy. It's not everything. It's specifically an E. coli that's sensitive to, say, amoxicillin.
So you switch?
You switch immediately. You stop the carpet bomber and you switch to the sniper rifle, the narrow-spectrum agent. That process is called de-escalation.
But I imagine in a busy hospital, it's easy to just forget. The patient's getting better. Why rock the boat?
That is the trap. The patient is a febrile. Don't change the winning team. That mindset is what breeds resistance. The pharmacist's job is to prompt that review.
To be the reminder.
Yes. Hey, the cultures are back. Why are we still on meropenem? We can switch to oral ciprofloxacin.
Wait, switching to oral meds is part of this too? I hadn't thought of that.
It's a huge part of it. The IV to oral switch. It gets the patient out of the hospital faster, reduces the risk of line infections, and is generally cheaper and safer. That is all part of the stewardship review process mandated by NG15.
There is another element in NG253 that I think gets overlooked because we're so obsessed with the drugs. It talks about finding and controlling the source of infection.
Source control, yes. It is absolutely fundamental, and often it's ignored.
I like the analogy of a fire here. Antibiotics are like the fire department spraying water on a house.
Right, but imagine that in the basement, the main gas line has ruptured and is just spewing fire. You can spray all the water you want. You can use all the broad-spectrum antibiotics in the world. But if you don't shut off that gas valve, the fire never goes out.
So in a patient, what is the gas valve? What's the equivalent?
It's the abscess full of pus. It's the infected central line. It's the perforated appendix. If there's a collection of infection, antibiotics cannot penetrate it effectively. You have to drain the pus, remove the line, or, operate.
And NG253 explicitly lists finding and controlling the source as a key recommendation.
It does. For a pharmacist, this means if you see a patient on day 5 of heavy antibiotics who isn't getting better, your question shouldn't just be, do we need stronger drugs? It should be, have we missed the source? Is there an abscess we haven't drained?
That is a powerful pivot in thinking. Okay, we've covered the clinical logic. Now I want to shift gears to something very, very practical. Many of our listeners are studying for exams or they're training juniors. Phrasing matters. How do you talk about this without sounding like you don't care?
Right, the examiner's checklist. You have to speak the language of the guidelines.
Give me an example. If an examiner asks about reducing antibiotic usage and I say, we need to use less drugs, I fail, right?
You don't fail, but you sound simplistic. It sounds negative. Instead, you look at the overview of NG15. You say, we need to ensure antimicrobials remain an effective treatment. It frames the restriction as a positive preservation effort. You aren't denying care. You are preserving efficacy for the future.
What about responsibility? It's so easy to pass the buck to the doctor.
That's a big trap. The guidelines, both NG15 and NG253, have a section specifically titled Your Responsibility. It puts the onus on commissioners and providers. So the phrase you want to use is, commissioners and providers have a responsibility to enable the guideline to be applied.
Enable the guideline to be applied. I love that. It implies that if the system is too understaffed to do a face-to-face sepsis assessment, the organization is failing its responsibility.
Exactly. It makes it a systemic issue, not an individual one. It shows you to understand that safety is about culture, not just about individual heroism.
Now, speaking of responsibility, there is a section in the sources that I think is the most real-world part of the whole document, the reporting of adverse events.
Yellow card scheme.
Yes. The source text says, all problems, adverse events related to a medicine or medical device should be reported.
To the MHRA, the Medicines and Healthcare Products Regulatory Agency.
I think people assume this is only for when a patient, has a really bad outcome or dies.
No, and that's a critical misunderstanding. Yellow card scheme is for signal detection. Let's say you notice that a new batch of IV connectors tends to leak a little bit. Is it fatal? No.
Yeah.
Is it annoying? Yes.
Right.
But if you report it, and 50 other pharmacists report it, the MHRA sees a pattern and can issue a recall.
So it's crowdsourced safety.
Exactly. Or if you see a patient having weird hallucinations on a new antibiotic, it might not be in a leaflet yet. Your report contributes to the data that updates that leaflet. It is a professional obligation. It's mentioned in the guidelines to report all problems, not just the catastrophes.
Okay, we are going to do it.
Do what?
The exam cram. I'm calling this the gauntlet. I have 12 questions derived strictly from the sources. I'm going to throw a scenario or question at you, and I want you to tell me the answer and why it matters.
I'm game. Let's go. Fire away.
Question 1. I have a 15-year-old patient with a fever and tachycardia. I'm pulling up NG253 to manage them. Am I right or wrong?
You are wrong. Dead wrong. NG253 covers people aged 16 or over. You need the pediatric guideline. Using adult criteria on a 15-year-old is dangerous because of that physiological compensation we talked about earlier.
Nice. Question 2. NG253 has a specific exclusion criteria regarding pregnancy. What is it exactly?
It excludes people who are pregnant or have recently been pregnant. Their physiology is totally different. Higher blood volume, faster baseline heart rate. You need the specific maternal sepsis guidelines for them.
Perfect. Question 3. Shifting gears to NG15. What is the stated primary aim of this guideline?
To change prescribing practice in order to slow the emergence of antimicrobial resistance. And note the focus there on changing practice. It's about behavior modification, not just drugs.
Question 4. We just talked about this one, so this should be easy. Where do you report adverse events?
The MHRA yellow card scheme.
Question 5. In late 2025, NG253 was reviewed. What specific test were they looking at?
Procalcitonin PCT tests. It's all about moving toward that biomarker precision.
Question 6. Who actually decides to update these guidelines? Is it just some random bureaucrat?
No, it's a nice prioritization board. They're the ones who review new evidence and decide if an update is triggered.
Got it. Question 7. What is the time span of the current UK action plan we are working under?
2024 to 2029. We are right in the thick of it.
Question 8. Back to the golden hour. NG253 lists antibiotic therapy alongside what 2 other initial treatment?
Intravenous fluid and oxygen. It's the triad of support. Kill the bug, fill the tank, oxygenate the blood.
Question 9. True or false? Applying NICE recommendations is mandatory for practitioners. If you deviate, you are breaking the law.
False. And this is so crucial. The text says they must be taken into account, but they do not override the responsibility to make decisions appropriate to the individual circumstances.
So clinical judgment trumps the guideline.
Clinical judgment always comes first. If the patient has a complex condition that makes the guideline dangerous for them, you use your brain, not just the book.
Question 10. In NG15, apart from the patient, who else is the guideline written for?
It's for health and social care practitioners, and this is the important part, organizations commissioning or providing care. It targets the bosses, not just the workers on the ground.
Question 11. Regarding our gas valve analogy, what does NG253 say must be done regarding the infection's origin?
Finding and controlling the source of infection. Don't just treat the smoke. You have to put out the fire.
And final question, number 12. The 2024-2029 plan is part of a bigger picture. What is the overarching vision?
The UK 20-year vision for antimicrobial resistance, AMR. It's all about the long game.
You survived the gauntlet, but knowing the right answers is only half the battle, isn't it? You also have to know where the traps are.
The pitfalls. The things that trip you up when you're tired or stressed or under pressure.
Exactly. We've identified 6 common pitfalls based on the Your Responsibility and Scope sections in these documents. Let's walk through them. Pitfall number 1.
Ignoring individual needs. This is the robot doctor problem. The source says you must take the guideline into account alongside the individual needs, preferences, and values of their patients.
So what does that look like in reality?
Well, if a patient refuses blood products due to religious beliefs, or if they refuse admission, you can't just wave NG253 at them. You have to treat the human in front of you.
Okay, that makes sense. Pitfall number 2.
Applying NG253 to the wrong age. We covered this, but it's probably the most common exam fail. If the case study says 14-year-old and you write, apply NG253, you get 0 points. End of story.
Pitfall number 3 is similar, I'm guessing.
Exactly. Applying NG253 to pregnancy. Don't do it. The risks to both the mother and the fetus are completely different. Separate guideline for a reason.
Got it. Pitfall number 4.
Treating guidelines as law. We touched on this. If you are rigid, you are dangerous. The guideline is a tool, not a shackle. It's there to support your judgment, not replace it.
Pitfall number 5. Now this one is interesting because it feels very modern. It's about the environment.
Yes, forgetting environmental impact. The guidelines explicitly state that commissioners, the people who fund the services, should assess and reduce the environmental impact of implementing NICE recommendations.
Why does a guideline on sepsis care about the environment? That seems like a strange connection.
Because antibiotics in the environment drive resistance. If we pour tons of antibiotics down the sink, or if hospitals don't treat their wastewater properly, that drug ends up in the rivers.
And then
Bacteria in the river get exposed, they develop resistance, and then that resistance finds its way back to humans. Stewardship is environmental protection.
that is a massive connection that I think most people miss. And finally, pitfall number 6.
Neglecting reporting. Simply fixing a drug error isn't enough. If you catch a near miss or you see a side effect and you don't yellow card it, you have failed the responsibilities section of the guideline.
Why is that a failure? You fixed the immediate problem.
You fixed it for one patient, but you haven't fixed it for the system. You've withheld the data that could prevent it from happening to 100 other people.
So let's zoom all the way out. We started with that split screen, the chaos of the ER and the quiet of the pharmacy.
And I think we've learned that the pharmacist is the bridge between them. Sepsis requires speed, that's the ER. Resistance requires stewardship, that's the pharmacy. And the 5-year plan is the blueprint for that bridge.
It really highlights that being well-informed isn't just about knowing facts. It's about knowing which fact applies at which moment. Is this a start broad moment or a de-escalate moment?
Exactly. And I think there is one final thought we should probably leave the listener with, a bit of a provocation.
Go for it.
The 5-year plan ends in 2029. That's just around the corner, really. We are racing against a clock that isn't just about the golden hour for one patient in an emergency room, but the golden era of antibiotics for everyone. We have lived in this magical time where infections rarely kill young, healthy people. That era is not guaranteed to continue.
So the question is?
The question is, if we follow these guidelines, if we really steward these drugs correctly, can we extend that golden era? Or if we fail to implement the systems NG15 talks about, are we just managing the decline? The answer depends entirely on what we do in that quiet room on the right side of the screen.